Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and I'm joined on the podcast today by Monica Boulton, who's Healthcare Integration Lead at the National Academy for Social Prescribing. Welcome, Monica, to the podcast.
Thank you. It's great to be here.
Now, NASP is a national charity that champions social prescribing, and Monica was, in fact, herself previously a social prescribing link worker. Now, I read on the NASP website that it's estimated that almost a fifth of GP appointment time is spent on non-medical problems, things like loneliness, isolation, stress, or financial worries. And so it seems that social prescribing is a really key area that could be helping GPs with their workload on this front. So to start with, you mentioned to me earlier that social prescribing was sort of formally introduced during COVID, and that as a result, there is perhaps not a consistently sort of well understood definition of what it includes. So could you just give us a bit of background then so that we're all on the same page?
It was actually sort of first introduced back in 2019, so just before the lockdown, and it was all part of the NHS long-term plan, which is where we, for the first time in history, saw that there was a non-medical workforce that was mandated within primary care. And as part of that, there was something which I'm sure listeners will be aware of, the additional roles reimbursement scheme. And one of those roles that money unlocked was the social prescribing link worker. So many link workers came into primary care in 2019. As we all know, is just before most people's lives changed in the pandemic. So I think it gave us a real kind of insight into how flexible that link workers can be in terms of how responsive they could be to the immediate changes that meant for primary care. But it did mean that we often saw link workers being redeployed into services like vaccine clinics, more general kind of welfare checks, rather than the kind of in-depth role that they can really provide within both primary care, secondary care and community settings. So as such, I think it's really helpful to kind of ground ourselves in the global definition of social prescribing. And this was accumulated through a Delphi study that happened in 2022-2023, led by Caitlin Mull. And I think it's just really useful to remind ourselves of this definition because it encapsulates exactly what we mean when we use the term social prescribing. And so that global definition is a means for trusted individuals in clinical and community settings to identify that a person has a non-medical, health-related social need and to subsequently connect them to non-clinical supports and services within the community. That's done by co-producing a social prescription. That's a non-medical prescription to improve health and well-being and to strengthen community connections. So I think it's quite useful to break that definition down into three parts when we think about the function that social prescribing provides. So that's your trusted individual in a clinical or community setting. You've got the co-produced prescription, so the support to connect to other services, and then that subsequent support and services within the community that improves the health and well-being. We know that to often exist within the voluntary sector. So hopefully that gives a kind of broad but useful overview of exactly what we're talking about when we're talking about social prescribing.
Thanks, Monica. Yeah, I mean, that leads me on. When I was preparing for this interview, I was thinking when family doctors, when that existed as a concept, presumably this is always something that would have been done in primary care. They would have been advising their patients on social, emotional, that kind of support that primary care would have always played. Is social prescribing then, is it kind of an extension of that?
I think it's fair to say that the concept of social prescribing has been around since the dawn of time. Faith sectors, for example, would probably say that they've been doing what we're calling social prescribing since, for their whole kind of careers and the history of those faiths. I think the important thing is that what social prescribing link workers are able to give, which doesn't really exist within our NHS at the moment, is the time to really understand the social determinants of health, the time to really understand not just the symptom that patient might be presenting with, but the cause and where that might be coming from. The whole ethos of that conversation and that consultation that a link worker will have is what matters to you, not what is the matter with you, but what matters to you. First consultations often last up to an hour which we just know that our GPs don't have. I think it's also important to remember that, yes, we've got these social prescribing link workers that are very embedded within primary care, and we're seeing pockets of it within other settings, such as within hospitals, discharge teams, and more community-based services. But that function that social prescribing provides, that motivational interviewing, that what matters to you conversation, can exist outside of that role as well. And so I think the kind of ethos of social prescribing, which ultimately is around person-centered care, it can be inherent in other roles beyond the link worker as well.
So speaking then about specific roles and how it can exist in different contexts, I'm sure that our listeners, particularly those working in primary care, will be familiar with their own kind of local setups for social prescribing. But could you give some more of the context on a kind of national level as to how different areas kind of make it work?
In many cases, that's right. Ultimately, the additional roles reimbursement scheme was set up so that primary care networks could really tailor their workforce around their population needs. And so it's right that different services might operate with nuance around it so that they can really serve the needs of the population. As such, there was something called proactive social prescribing that came out as guidance a couple of years after the introduction of social prescribing, that really encourages them to look at their population needs and to tailor their social prescribing services accordingly. But there's also a lot of integrated commissioning models around social prescribing. So beyond the additional roles reimbursement scheme, we also see ICBs commissioning social prescribing services, local authorities commissioning social prescribing services, and some social prescribing services even starting to pop up, like I said earlier, in settings such as secondary care, in hospital discharge services, in A&E settings. And so there really is a huge sort of variation around exactly how it's operating in different settings. I think that's what the global definition really helps us to do, is to really ground everything and create that kind of consistency, which really is around that kind of what matters to you conversation, and subsequently connecting people onto support. The other reason for variation is the kind of latter part of this, which is around what link workers are connecting their patients into. And as I said earlier, a lot of that exists within the voluntary sector, and it will be no surprise to anybody the kind of constant challenges and changes that exist within the voluntary sector. And so subsequently, that kind of whole system offer is going to be very determined by exactly what exists in that community and what's available for individuals, and what link workers can therefore connect their patients to.
When I'm thinking about social prescribing, I was really interested to hear you actually saying about the different pockets that are popping up in sort of A&E and secondary care, because I hadn't really considered that. Certainly for me, the first thing that comes to mind when I think about social prescribing is around like older people, perhaps those who are lonely or isolated. But which other groups are there that you think, would stand to benefit from social prescribing? And, are there any groups that you think for whom that social prescribing is perhaps underused?
Yeah, so I think social prescribing, when we look at it, what's happening globally around social prescribing, because it's not just taking off in this country, it's taking off around the globe, we really see that social prescribing can be both applicable within a prevention space, so keeping people well, keeping people in the community, but we can also see it as something that can really support people across their healthcare pathways. So when people are experiencing conditions, the major conditions, long-term health conditions, there's a space for social prescribing link workers to exist in kind of the latter stages of somebody's care, more acute care. I think when we're looking at the different pathways that exist for different long-term health conditions, along that pathway, there will always be various points at which that conversation happens of what next. What does this next chapter of your journey look like? And I would really advocate that social prescribing should always be part of that conversation, should always be part of that holistic care. Social prescribing, when it was implemented, was always intended to be an all-age service, so very much applicable from cradle to grave in terms of the people that it can support. But I think the majority of referrals that we see are for the older population and people that are already kind of accessing health services by the very nature of the fact that it's kind of based within primary care. The other thing that we're starting to see in a real growing area at the moment is social prescribing for children and young people. And social prescribing for children and young people, what we're finding is that it needs to be set up slightly different, because that's a cohort of people, of patients that have got a different set of needs. It might not be at most appropriate for them to access social prescribing through settings such as primary care. So there's a lot of exploratory work going on at the moment about how social prescribing can support children and young people, particularly particularly within the mental health arena, both through that kind of prevention piece and keeping people well, but also how can we embed social prescribing within services such as CAMS so that those children have got an opportunity to have that more holistic conversation and really understand what it means to kind of look at all of the different social determinants of health in their journey. So I think major conditions is something that is also really kind of coming to the forefront, and there was actually a commitment that there was the social prescribing was mentioned in the latest major health conditions strategy, and there was a commitment within that to expand social prescribing beyond GPs and across healthcare. So that's really encouraging and shows that there's a commitment there and an understanding that social prescribing, yes, it's very relevant and important to have that in primary care, but it can also go across the different settings that we see in terms of supporting people as well.
So you mentioned about prevention is obviously becoming increasingly important, with prevalence of long-term conditions and stuff like that. What would it look like then for a clinician to use social prescribing in that context, in the context of prevention?
So I think this is when what we would describe as the kind of whole system approach to social prescribing really comes into play. So it's around what are other sectors' contributions to social prescribing? Where can those integrated commissioning models really come into play? Where can those link workers physically sit despite them being perhaps recruited by a primary care network? So, for example, we know that there is a lot around the kind of pharmacy first agenda at the moment. Is there a space for a link worker to sit within a pharmacist, so that when people are coming into that space rather than into the healthcare service, they're having that conversation with them around what their needs are, what their priorities are, what their health issues look like, and how non-medical interventions might be able to support them. So I guess the encouragement is to be creative. Link workers know and understand their community. They've got the time to not just understand the assets that are out there in terms of the voluntary sector and the services that they're referring into, but really understand the demographics of the area too. At the moment, there is no requirements for link workers to have any formal qualification to become a link worker. The recommendation is simply having good communication skills and IT skills. And I think that's a real asset to the workforce. When I was managing a team, that was what gave us a lot of strength, is that I had a workforce that was representative of the community that they served, that had lived experience, that meant that they were able to really have a non-hierarchical conversation with that individual. And I think that that's a real strength. So utilizing and being creative with that incredibly skilled and incredibly knowledgeable workforce, and physically placing them in other settings, but also thinking about how creatively they can be accessing people that might not generally be comfortable coming into a healthcare setting, can be really powerful.
Yeah, absolutely. And that leads me on to thinking about the health inequalities aspect, and tackling health inequalities is focus of ours at MIMS Learning at the moment. And, that social prescribing is an important kind of tool here. And, you were talking about being part of the communities that they're working with and really understanding the issues faced by those communities. So can we talk a bit more about that, around sort of how social prescribing can contribute to tackling health inequalities?
Yeah, of course. When we see social prescribing within the context of person-centred care, it's around really supporting that individual. And I think that social prescribing also works best when we see it in the kind of context of that multidisciplinary team. So I don't think that it would be helpful to say that kind of social prescribing is the answer to health inequalities, but it plays a really important function in terms of getting to know exactly what, like I say, those social determinants of health are. I think that there is more work to be done in this space, and there's lots of research going on at the moment in terms of exactly the kind of the evidence base for social prescribing around health inequalities. But what I would say is that there is a real place for social prescribing to be based within the community, so that they're going to be accessing people that we would perhaps term as hard to reach, and having those conversations with people and placing themselves in settings. Social prescribing link workers are often described as the bridge between healthcare and the community, and I think that's a really beautiful analogy, in that where there are two sectors that are often speaking incredibly different languages, and there's quite often a patient in the center of that trying to navigate those things. link workers can really help to break down those barriers and encourage different ways of accessing those services. An example of that might be is link workers that perhaps are working really closely with the voluntary sector and might be working really hard to kind of set up volunteering schemes that sit alongside their social prescribing service to physically help people to get to the places that they need to go to. So that, as you can see, that's a way in which social prescribing can identify that barrier, is that there is no physical way for somebody to get into a specific service or a specific activity, and they can mobilize the assets that exist within the community to break down that barrier and increase access, thus reducing that inequality. So there's also lots of kind of work going on around specifically targeting cohorts of patients and different groups. But again, it's that kind of creativity aspect behind it, I think, that enables social prescribing to really be in that space where they're not just understanding and knowing the community, but they're able to mobilize the assets around them so that there is more equity of access to the things that they need.
We've talked a lot about social prescribing and how it can work. And I love that analogy also that you used of it being a bridge between the community and healthcare. So, how do you actually measure the success of social prescribing? What are the kind of parameters that you'd use?
This is an ongoing challenge, I think it's fair to say. I think there's three different categories that you can measure, and I think it's around measuring the impact on the individual and the outcomes that it has for individuals. It's about measuring the impact on the community. So what impact is social prescribing having on that voluntary sector that I've talked about a lot already, but the other kind of services and activities that will be being referred into, whether they're local authority services, voluntary sector services, or statutory. And then there's also the impact that it's having on the healthcare system. And there's already some really promising evidence coming out in terms of there being between 15 and 25% reduction in emergency and unplanned hospital care. So really seeing a reduction in that healthcare utilisation. We're seeing 20 to 40% reduction in GP appointments for patients that have been supported through social prescribing. But we're also seeing really encouraging, as I say, kind of outcomes for individuals in terms of that reduction in isolation and improvement in health outcomes. But there's loads of evidence briefings that we've got on our website that go into much more detail than that, and evidence is always emerging at the moment. There's some really exciting work going on in that space, so keep an eye on our website and social media, etc., to keep in the know about all of that sort of thing.
It's always nice to have some good news stories. So, do you have any examples of specifically sort of social prescribing initiatives where they've been really successful, where they've had a really significant impact on a specific patient's journey?
NASP last year actually had a campaign, a media campaign called Social Prescribing and Me. And that took us through some of the patient stories, case studies, if you like, of how it's really kind of impacted an individual's well-being. I think some of the stronger cases that we see is where there really is that multidisciplinary team approach and a real sort of whole system that surrounds the social prescribing service. And it really becomes around how services can really effectively work together. I think one case study that always comes to mind from my background was when I had an individual who had been in and out of mental health services her whole life and had really struggled with her kind of confidence and getting out there, and had a real interest in kind of arts and culture. And we worked together to really get to the bottom of exactly what mattered to her. And essentially she went from being somebody that never left the house to being somebody that was putting on her own art exhibition in a local gallery. So I think that really demonstrates quite how transformational social prescribing can be for patients and for people's lives. There is a wealth of case studies and good news stories about that. And I think if you ever get the chance to speak to your link worker, they will have an absolute wealth of different case studies in terms of how they've supported people. So go and have a chat to them, because it really does show the power and the impact that they're having through the work that they're doing.
So, to finish up, then, how do you see the future of social prescribing? Clearly, it's a kind of an evolving facet of the system. So, where do you see it going in the future?
Possibilities are endless kind of comes to mind as a phrase, really. I think it's about integrating it in more long-term health condition pathways. I think it's secondary care. There is a huge gap at the moment for something like social prescribing to really come to the forefront of that space. And I think it's around us really leaning into the development of integrated care systems and that real sort of cross-sectoral approach. And so I think there's lots more to be done in terms of supporting other sectors to really understand what contributions they can make to social prescribing that subsequently will have an impact on link worker practice and obviously the patient's health and well-being as well. So I think secondary care is probably the kind of biggest opportunity at the moment, but I think it's also about kind of continuing to embed what we're already doing and making sure that it kind of becomes more business as usual rather than this kind of new initiative that's still developing.
I've certainly learned a lot about social prescribing in the last 20 minutes or so. Was there anything else that we've not covered that you wanted to talk about?
It's difficult to kind of get into all of the nitty-gritty detail around social prescribing in such a short space of time. So I would just really encourage everybody to reach out to NASP if you do want to get involved in any of our work or hear more about what social prescribing is all about. We have a variety of advisory groups and communities of practice, so there's lots of opportunities to get involved. And we've got loads of resources on our website, including case studies and a lot of evidence briefings and things. So our website address is socialprescribingacademy.org.uk.
Thank you very much, Monica. It's been great having you on the podcast. And for all of our listeners, we hope you'll join us again next week for the next episode of the Clinical Update podcast. See you then.